Advocacy United workshop webinar, where we are so glad today to have Andreea from Mended Hearts Europe to make a presentation. And because we only have an hour, I am so glad that Andreea, you had the opportunity to make this presentation for us, because this is one of the really most overlooked assignments in an organization. So, and I think from stakeholder side, this is very important for us to really understand the backbone of what we are doing. So I'm so much looking forward to it. So welcome, Andreea, and I'll give the floor to you.
Lovely. Thank you very much, Elizabeth. Hopefully everybody can hear me very well. Thank you very much for the kind invitation. It's really a pleasure to be here, and it's really an important subject that we're very passionate at Mended Hearts. My name is Andreea Gheorghe, and I'm the Director of International Affairs at Mended Hearts Europe. And in my role, I lead the collaboration with patient organizations across Europe. We work together to implement educational and structured peer support initiatives that strengthen patient engagement and help build a stronger patient community. And a big part of our work actually focuses on how we can translate lived experience into practical structures, making sure that patients and families are not only supported, but also actively involved in shaping care and engaging at both national and European levels. But today I'd like to share with you how we approach building sustainable patient communities across Europe, not just through projects, but also through structured peer support, education, and collaboration with healthcare systems. So what I'll do is I'll walk you through who we are, why patient and peer support matters in our context, and two country examples, France and Northern Ireland, where we're currently implementing peer support models. A few words about who we are. We are a relatively young organization. We were established in June 2023 as an independent association under the Swiss law. We're based in Geneva, Switzerland, but we like to joke and say that we are a startup with 75 years of experience. And that's because we're part of the Mended Hearts family, which was originally founded in 1951. And this month they are celebrating their 75-year anniversary. And today, Mended Hearts Network includes more than 127,000 members in over 40 countries and is the largest peer-to-peer cardiovascular support network in the world. Our focus is supporting people of all ages with or affected by cardiovascular conditions and related comorbidities. And from day one, our peer support element has been part of our DNA. And the real question for us when we launched the organization in Europe has been how we can adapt the legacy of our colleagues into structured, system-aware, very different national healthcare contexts. Our vision is simple. We believe that every cardiovascular patient should have the resources and support needed to live a healthy life. And our mission is structured through these three pillars: to support by implementing structured peer support initiatives such as Welcome Home program that I'll tell you a little bit more in a few minutes. Educate by producing multilingual, very practical, patient-friendly resources. We have go-to guides, discussion guides, infographics, and different animations. And by advocating and bringing patient voice into system and also into policy conversations. Our strategic objectives is to expand support across Europe, first by adapting, translating, and co-creating with national patient groups educational resources. We also partner with local patient groups to build peer support, and you will see a few more about this in a couple of minutes, and also empowering patients as advocates. But for us, these are not separate silos. They reinforce one another. A few elements about our programs before we move into the country examples. I just wanted to show you briefly the scope of our program. I'm not going to go into details into each of these programs, but in just 2.5 years, we've built a fairly comprehensive portfolio across cardiovascular diseases, but also risk factors and topics that are emerging. So you will see that some areas are marked with an asterisk. That means those are programs that we would like to launch this year. The rest have been developed over the past 2.5 years. And for a relatively young organization, this is something we are quite proud of. But what's important to us is not just the number of programs, but the fact that they are interconnected. So, for example, we worked on educational resources for high LDL cholesterol, which is a major risk factor for heart attacks and stroke. So our resources are designed to complement each other and guide patients across the continuum, not just within one condition or one risk factor. Another example is the link that we're trying to build between chronic kidney disease, so an area outside of the cardiovascular field, and cardiovascular disease. Heart failure patients, for instance, need to understand their risk of increasing their kidney complications. So we align these topics. We made sure that they're not in isolation. Over time, we're not just creating individual resources, we're building a coherent library that reflects how these conditions are connected in real life. Beyond individual programs, we are really building an ecosystem. So our broader ecosystem includes multilingual educational resources, over 18,000 printed material distributed directly through hospitals and different community settings, more than 12 educational web pages, patient stories through our Heartfelt Stories section, and also over 12.7 million digital impressions across campaigns in 2025. These are figures that we wanted to highlight from our 2025 annual report, but the numbers are not really the point. The point is the education and the support and the visibility that reinforce one another. When patients have access to clear information, when they see others sharing similar experiences, when they feel visible and represented, communities become stronger. And stronger communities obviously are more resilient. This is the foundation that allows patient support to truly work. And this brings me to why peer support matters. And when we talk about resilience, this is where peer support really becomes critical, because across Europe, regardless of healthcare system, we see the same recurrent challenges. Patients experience emotional shock at diagnosis. Information can feel fragmented or overwhelming. The time that they have with their healthcare provider during their medical appointment is limited. We've all experienced that. The period after hospital discharge can feel isolating. Carers can also play a significant role in a patient's care by also taking on a significant burden. So clinical care is essential, but is not always enough. So that's where peer support can fill in what is often described as the human gap, the space between the medical treatment and the lived experience. We do not launch informal peer support groups. We build structured, co-designed, and system-aware peer models. Models that complement clinical care, models that do not replace clinical care. They are aligned with national pathways. They include proper volunteer training. They are evaluated, and they are also built to last. Because we believe that peer support, when done without structure, can be well-intentioned but fragile. But when it's embedded within the system, it becomes a force multiplier for patient confidence, engagement, and also continuity of care. And this is exactly what we're now implementing in practice. So I'm going to walk you through the 2 case studies Number one, France. I'm going to give you a little bit of context. We are adapting our welcome home model for hypertrophic cardiomyopathy, or HCM in short, which is a disease of a heart muscle. France has a very strong specialist network and well-established therapeutic patient education structure. So from the structural point of view, the system is quite robust. However, what we have heard during the roundtable discussion that we organized last September in Paris from both patients and clinicians is that the moment of diagnosis remains highly vulnerable. Patients experience shock, communication can feel fragmented, and there's a clear need for psychological support along clinical trial follow-up. What was particularly encouraging is that clinicians expressed strong interest in peer support, not as a replacement, but really as a complement to medical care. So the challenge was not convincing the stakeholders that peer support matters. The challenge was defining how it should work. Based on the context, our focus has been, therefore, on this very careful adaptation. First, alignment. The model must align with local structures. It cannot operate in parallel. Second, role clarity. The role of the peer support, the volunteers, must be structured and also clearly defined, supporting patients but never replacing clinicians. Third, volunteer preparation. Training must include empathy, boundaries, confidentiality, ensuring quality and safety. And finally, legitimacy. So for peer support to scale, it must be recognized as part of the ecosystem, not as an informal add-on. In terms of next steps, we're now in process of refining patient needs assessments, establishing an operational working group and adapting the training models into the French culture and also systemic fit. And so far, the key lessons from France, integration is everything. And if peer support is aligned with existing pathways, it becomes an asset. If it's disconnected, it struggles to survive. Now, let me move on to a different context, Northern Ireland, where we are adapting welcome home model for heart failure this time. And the healthcare context presents distinct challenges, distinct from France. Here we're talking about workforce shortages, diagnostic delay, but also what they call it is a postcode lottery, this very significant regional inequalities across the different trusts. So for the pressure of the system, that is something that is visible and it's also felt by the patients. And to understand how peer support could realistically fit, we organized, again, a roundtable discussion where we brought together patients, care nurses, cardiac rehabilitation teams, GPs, and academics. And the diversity in the room was essential. I cannot tell you how important it was in the beginning to have everybody present in the room, because peer support cannot be designed in isolation. It must reflect the real pressure of the system. And what emerged from the discussion was that transition period, especially early discharge, is a very highly vulnerable moment. Patients are overwhelmed, carers feel this significant responsibility, and also clinicians recognize that consultation time alone cannot address everything. We have a brilliant team on site there that we're going to visit tomorrow. And out of the discussion, we have decided to pilot an implementation trust in the Southern Trust. This has been identified as a strong place because there is engagement, there is an existing community structure, and our partner on the ground, the Heart Failure Warriors, have already done some work with patients and they're ready to collaborate. So this is where we are starting the implementation. And rather than doing something nationally, we're beginning in a setting where alignment and commitment already exist. And that really will allow us to build, test, and also refine the model in a very realistic way. What emerged from the discussion was this strong alignment around these four key points. Again, regarding the early discharge needs for a structured follow-up and support, and we were just talking with somebody who was discharged from the hospital and had to wait around 3 months for her first appointment with a heart failure nurse. And it was a time where she was lost. She was obviously looking online for information and trying to find trusted resources. It was a very difficult moment, and that is what everybody in the room has shared as an experience. Carers were also in the room, and it was also important to highlight the need to intentionally include them and not treat them as an afterthought. And also peer support can reduce fear and misinformation by providing reassurance that is grounded in lived experience. And most importantly, community-based models can relieve the pressure that exists already on these very stretched clinical teams. So in this context, peer support was not seen as an optional idea. It was a very practical element that could complement care. And in terms of next steps, we're now moving into the implementation phase. We have a working group established. We are also developing the training for the volunteers, and actually tomorrow we're flying to Belfast to train the first cohort of volunteers who will be providing peer support as of this May. And we're also working on a monitoring and evaluation framework from the outset, because if we want peer support to be credible, we have to measure. So when we take a step back from France and Northern Ireland, we have seen a few clear lessons so far. First, co-design is non-negotiable. If patients and clinicians are involved from the very beginning, then it's absolutely incredible. If not, the model will struggle later. So this shared ownership creates trust and momentum. That's why we had so many people involved in the first initial conversations. Second, the alignment with existing care systems is essential. Peer support cannot be something that is bedside the system. It has to sit within. Third, train volunteer, and this I cannot stress enough. Volunteering is an incredible thing, but it has to be trained, and it has to be very importantly set within certain strict barriers. Empathy is important, but also boundaries, clear roles, and ongoing support for volunteers who are also patients themselves. Fourth, we must measure impact, not only to demonstrate externally the value of it, but to refine and also strengthen the model internally. And finally, scalability must be planned from day one. If you design something that only works in one hospital, it will stay there. But if you design something that is adaptable, it can travel. So for us, these 5 principles now guide every adaptation we undertake. I've tried to stay within the 20 minutes that have been given to myself. So thank you very much for your attention. I hope that what I've shared today has offered not just examples, but some practical insights on how peer support can be structured, integrated, scaled across different healthcare systems, because it can be also within other areas, not just in the cardiovascular field. And we are still learning, and we truly see this work as collaborative towards clinicians, towards different patient organizations. So if any of these approaches resonate with you, or if you are working on similar initiatives within your own organization, I would generally welcome the opportunity to continue the conversation. And also feel free to contact me on LinkedIn or reach out by email. I'll be very happy to exchange ideas and explore potential collaboration. So thank you very much, and I look forward to the discussion.
Thank you so much, Andreea. It was really, really insightful, and I love the way that you're bringing in that peer support was something that we should look at as an organization. But
in our case, cardiovascular disease unfortunately can touch very young individuals, but also individuals who are older. And this is, again, something that has come up in our discussions in France. We have a 25-year-old volunteer who is very passionate about what she's doing, and she's really willing to train other individuals. It's I would say the problem is the age that we're targeting the programs to. So in the case of hypertrophic cardiomyopathy, it can touch individuals very young. So it's definitely a clear need for us to have those young individuals who are very at the beginning of their journey, I would say, living with heart condition, or even with the transplanted heart as well, to be involved with others who are now navigating high school, or looking for a job, or looking for starting their own family. And this is the kind of diversity that we're looking at having within our trained volunteers. And this is something that I think it comes also with the age group that the disease area focuses on. In the case of heart failure, we're talking about 45 plus individuals, because that's when heart failure starts to show signs and symptoms. And we have a young mother who is raising awareness among other women, not necessarily within that category of age, of the dangers of developing this disease at a younger age. So again, breaking also some of the stereotypes that heart disease is for older generations, and looking at identifying those voices, or those advocates who can then be an inspiration for other individuals who are like, I can do also the same thing. I have an experience that I can provide and can be helpful, and others can learn from, and really look for hope, because I've managed to finish high school. I now have a job. I will start a family. So these kind of examples, I think, are very important to highlight them when you have them within your community, and then using them as examples to recruit, if I could put it this way, other volunteers.
okay, thank you. I actually have a side question on that, because I know that we have a whole generation that actually are not involved in the disease area. And that is the young ones, the ones who don't think they're getting the benefit. And what I think is, you're talking about heart diseases, Camilla talking about psoriasis diseases. There is a huge problem here. Is it something that we as organizations can be aware of and pushing forward, so we can help organizations like yours, like Amelia's, like Camille's, so we can push for that young people can actually benefit and get a better life with these kind of knowledge, with this kind of experience also? Is that something that we can help with visibility, or what do you think? How can we help you, if we can help?
I think it's always important to be more visible online. And when I say visible, it's really utilizing the channels through which we can really look at the generation that we're trying to attract. So they're using social media. Why not? Let's find ways to engage with those individuals through social media, or let's find them in schools. And in the US, I'm not going to get into details, but in the US, we also have support for young adults, so people who are between the age of 18 plus and 55. So those who should not have necessarily heart disease, but unfortunately have due to different genetics and due to different other elements. So we are targeting individuals in that area specifically because there is also a larger group of patients that could benefit from those insights. So I would say trying to go to high schools or universities and using the power of social media that today exists to really target individuals who either have interest in health, who have a grandfather who had a heart attack, or somebody else in the family, and trying to make the link between them and that specific message in order for them to be able to then decide if they want to be involved, if they want to give back to the community, they want to support somebody the way they're supporting their grandfather or their other family members. So yeah, trying to go where they are, because it's I would say it's easy to wait and see if they come to us. Experience says that it's obviously easier if we go where they are and if they resonate with our message in a way.
Okay, thank you everybody for today, and may you have a very, very lovely afternoon, everybody.